All right, good afternoon and welcome to this public webinar on strengthening coordination across the social safety net for patients with addiction, which has been jointly organized by the National Academy of Medicine and the American Society of Addiction Medicine. My name is Elizabeth Finkelman and I direct the National Academy of Medicine's Action Collaborative on Countering the U.S. Opioid Epidemic, which I will describe further in a minute. The Action Collaborative has benefited greatly from the participation and leadership of the American Society of Addiction Medicine, represented by Dr. Kelly Clark, and we're so pleased to be collaborating on this webinar together. Today's free 90-minute webinar is the third in a series called Supporting People with Addiction During COVID-19, hosted by the NAM and the American Society of Addiction Medicine. Today's webinar has been approved for 1.5 hours of AMA PRA Category 1 credits and for 1.5 continuing education credits from NAADAC, the Association for Addiction Professionals. Please note that in order to claim credit and receive the certificate of completion, participants will need to complete the mandatory evaluation at the completion of the webinar. This webinar is being recorded and the video along with the presenter slides will be posted to the NAM and ASAM websites after the event concludes. Next slide, please. Today's webinar will last 90 minutes and will follow the agenda you see on your screens. We will begin with 10 minutes of introductory remarks provided by myself and Dr. Kelly Clark, who will be moderating today's discussion. We will then hear from our panel of speakers who will each speak for 15 minutes. And then we'll move into a moderated discussion with the panel before opening it up to questions from the webinar audience. And the webinar will conclude today by 2 p.m. Eastern. Moving to the next slide. Questions and comments from the webinar audience can be submitted at any point during the webinar, and we will do our best to get to as many of them as we can before our webinar concludes. So please use the comment box on your screen to submit a question. And as a reminder, the webinar is being recorded, so please understand that any questions you submit may be read aloud and included in our recording. Moving to the next slide, we hope that you will join the conversation on social media and tweet over the course of the webinar today by using the hashtags COVID-19 SUD treatment and opioid collaborative. Next slide, please. Now I'm just going to spend a couple minutes going over the NAM's Action Collaborative on Countering the U.S. Opioid Epidemic and providing a brief overview of our work. Moving to the next slide, recognizing the need for a cohesive and collaborative response to the nation's opioid epidemic, the National Academy of Medicine established the Action Collaborative on Countering the U.S. Opioid Epidemic in 2018 as a public-private partnership to foster greater coordination and collective action across the health system and beyond in addressing the opioid addiction crisis. The Action Collaborative uses a systems approach to convene and catalyze public, private, and nonprofit stakeholders to develop, curate, and disseminate multi-sector solutions designed to reduce opioid misuse and to improve outcomes for individuals, families, and communities affected by the opioid crisis. The Action Collaborative has 3 foundational goals that guide its work. The first is to identify and raise the visibility of complex challenges, outstanding gaps, and needs of the opioid crisis that require a collective multi-sectoral response. The second is to elevate and accelerate evidence-based multi-sectoral and interprofessional solutions to improve outcomes for those affected by the opioid crisis. And lastly, the Action Collaborative aims to catalyze action on shared priorities and solutions to help overcome the crisis and improve outcomes for all. The Action Collaborative's work is focused around 4 core priority areas, which represent among the highest priority elements of the nation's response to the opioid crisis. And these include strengthening health professional education and training around substance use disorders and pain management, improving pain management guidelines and evidence standards, accelerating, sustaining, and scaling prevention, treatment, and recovery services, and elevating pressing data, research, and metrics needs. Around these areas, we're producing several policy and technical white papers, as well as webinars, public meetings, and a variety of dissemination activities. Next slide, please. Of course, with the emergence of the global COVID-19 pandemic earlier this year, the Action Collaborative is now pivoting to focus on ways in which we can support the substance use disorder and pain communities during this challenging time. As such, we're undertaking a series of activities to be responsive in the near and longer term. We've created a resources page on our website to collate and share emerging COVID-19 resources across the Action Collaborative's membership, including those important resources that are put out by the American Society of Addiction Medicine. We've been conducting virtual town halls with the Action Collaborative members to share updates on ongoing efforts to address the impacts of COVID-19 on the opioid use disorder and substance use disorder, as well as pain populations. And in the coming weeks, our steering committee of cross-sectoral leaders will be releasing a statement highlighting critical priorities and actions that need to be taken in the near term to protect the health and well-being of individuals with substance use disorders and pain in the context of the COVID-19 pandemic. And of course, we'll also be highlighting pressing and immediate research priorities and needs, and generating publications and conducting webinars such as these on high priority topics. I've only really scratched the surface of what the Action Collaborative's activities are, so I encourage you to visit our website to learn more and sign up for updates. Moving to the next slide, please. Now I'm very pleased to introduce this terrific and talented group of experts whom you will now have the pleasure of hearing from today. Today's discussion, as I mentioned, will be moderated by Dr. Kelly Clark, who is the immediate past president of the American Society of Addiction Medicine. And joining Dr. Clark are Dr. Ingvild Olsen, who is the medical director of the Institutes for Behavior Research, Inc. and Reach Health Services. Dr. Elizabeth Salisbury Afshar, who is the director of the Center for Addiction Research and Effective Solutions at the American Institutes for Research, and Dr. Corey Waller, who is a principal with the Health Management Associates. Viewers can download and read their impressive biographies on the webinar event page to learn more. And with that, now let me please turn it over to Dr. Clark.
Thank you, Liz. Appreciate that. And welcome to all, and thank you for taking your time to hopefully learn some important and helpful information about treating addictive disease during COVID, with a special emphasis on the difficult and unique populations of justice-involved persons, as well as those experiencing homelessness. Next slide, please. The objectives, and I apologize for reading, I won't read many slides, but for those of you who are listening rather than watching, important for you to understand what we're really aiming for today. We'd like for you to leave this webinar being able to discuss the unique challenges to substance use treatment providers and patients during the COVID pandemic, and identify the strategies for infection mitigation and for minimizing risks for both patients and staff. We'd like for you to recognize the enhanced risks, as well as some patient-centered strategies for maintaining access to addiction treatment for these populations, and be able to identify successful strategies that our expert panel have been using on the ground in their practices. Next slide, please. So as Liz said, ASAM has been working very emergently during this time period on getting information from the ground on what's happening with addictive disease and treatment systems during COVID, and bringing it up to a national level while simultaneously understanding and working to make the changes necessary at the federal level, and then help people down on the ground understand what those are. The federal government may say, thou may, but the states will often say thou must. And so it's very important to understand what's happening down there on the ground and help communities and providers in the states to get the kinds of changes and pivoting they need during this time. Next slide, please. Oh, and just to remind folks that this is being recorded, and everyone's slides will be available on the websites at both ASAM and the National Academy in a few days. So there is a website where guidance is being put up, and if you just search in your browser COVID and ASAM, that's the American Society of Addiction Medicine, where 6,500 physicians specializing in addiction care and allied health personnel, you will come to the resource page. Next slide, please. And again, I apologize for going through this list, but again, for those of you who are listening rather than seeing, I want you to know what is available for you for resource out there. So there are published guidelines from the American Society of Addiction Medicine on infection mitigation in outpatient settings and residential settings, telehealth guidance, adjusting drug testing protocols, access to buprenorphine in office-based settings, access to care and opioid treatment programs, support group guidance, guidance on medication dosage and formulation considerations under COVID, treating pregnant women with OUD, criminal justice, guidance for general hospitals and homeless populations, all of this around addiction care during COVID. Next slide. We are almost done with putting up this guidance. We have 3 that are coming forward: clinician and physician well-being, access, actually 2, access to alcohol use disorder and withdrawal management services. We, ASAM did put up a guidelines for treating alcohol withdrawal, but overall guidance was found to be necessary. Next slide, please. And just for folks to understand the difference between guidelines, such as the alcohol withdrawal management one, and guidance, guidelines take over a year and 6 figures to put together with a very rigorous methodology. Guidance is a very rapid approach, which is what's necessary during this crisis, which relies on a handful of experts and a much faster approach. So what I've just spoken about, it was guidance. Next slide, please. And as we've gone through this process, we noted really 3 underlying themes that I just want to reiterate for those who may have heard this before. But the first is that clinicians and treatment programs and entire systems of care need to change their approach during times of disaster from what we consider to be traditional best practices, which is using all of the resources that we have available, following strict guidelines and et cetera to provide clinical care to an individual, to a practice where we are using the resources that are available, which are curtailed, where we are providing the best care possible under the circumstances that are available in this disaster situation for the patients in our community. And that pivoting is really one of the major underlying themes. Next slide, please. The second underlying theme to consider that's occurring is that rapid and deep federal guidance has occurred. Changes in regulation and changes in payment through CMS and others. That federal guidance needs to be implemented within the state and local regulatory and payment structures. And so that need to be interconnected in order to really provide appropriate treatment can't be underestimated, and that's an underlying theme as well. And then finally, there is an urgent and emergent, next slide please, need for clinicians and entire systems of care as well as treatment programs to break down from their silos and collaborate to build new systems of care. And by this, we mean some of the guidance we've talked about is separate when you have a low prevalence in the population of a disease, when you've got 10%, 15% of the population that is testing positive for COVID and may be infectious, you can isolate those individuals, the patients and the staff. But when you've got an increased population prevalence at later stages of the pandemic, when you're at 40, 50, 60%, you can't isolate those individuals. You can isolate populations. And some of our guidance talks about having patients with a high potential to be infectious be seen on certain days, and those with a low potential by demographic be seen on other days, and etc. But that need to build for the future right now is urgent, while taking the steps that we need to take during this first part of the pandemic. Next slide. And this just goes through that construct of the early phase, this middle phase that we need to build toward immediately. And then in the post-acute pandemic state, we adjust to a new normal with new best practices. Next slide. So just to say that we would like to hear from the field. If you've got protocols or approaches that you would like to share widely, or if you've got questions or concerns related to the guidance, please email covid@asam.org. Again, you can find the web page at just by Googling ASAM and COVID. And what we have also placed on the website are protocols that are being used by different clinicians, different facilities, different institutions. Some are being used, for example, Dr. Hurley's work in LA County, Dr. Weimer's work with the Yale medical system, on how they are pivoting and working at these population kinds of approaches in their different setting. And so we are putting up that kind of information for you as well, not as maybe best practice, but as an example of practice that will need to be, of course, tweaked to your own circumstances. Next slide. And so with that, I would like to hand this over to Dr. Ingvild Olsen.
Thank you so much, Dr. Clark, and thank you so much for all of you to being here on this Tuesday afternoon. And I'm going to, in the next 15 minutes, talk a little bit about kind of adapting practices to support access to treatment, particularly in vulnerable populations, as Dr. Clark mentioned. Next slide, please. So, throughout this epidemic, this pandemic, we have really highlighted the importance of maintaining access to care for people with addiction. And that is no different, and in fact, particularly crucial at this moment in time in our country when we are not only dealing with an opioid epidemic, but the COVID pandemic, and now also all the unrest that we see in various different places across the country. What we know is that COVID-19 has been associated with significant risks for people with addiction. Not only is there the stress and anxiety of addiction itself, but now when we are telling people to stay at home, to socially isolate, and people are afraid of this very serious infection, that only adds to the stress and anxiety that comes along with addiction. People have had new financial and family stressors. People have lost jobs. Unemployment rates have skyrocketed. People are losing access to the various different support services that they have had and been able to rely on. And we have seen that that has anecdotally led to an increase in alcohol and drug consumption. There are reports from places, states like California, New York. I am based here in Baltimore City in Maryland. And we have seen that alcohol consumption has increased, or alcohol sales have increased by 50 to 70%. So certainly we are seeing kind of increases in people who may have substance use disorders, have addiction underlying, but also may now be developing new onset of addiction that they did not have previously. And we also have are seeing that there are changes to the drug supply and the access of individuals who have substance use disorders. And we'll talk a little bit more about kind of what the risks are associated with that. So individuals with addiction are at a significantly increased risk, not only for COVID-19 transmission, but they also have a significant and maybe independent risk for severe illness. And those multiple risk factors include the populations that we're going to talk about. So the populations who have criminal justice involvement, detention centers, jails, prisons across the country have become hotspots for COVID transmission because of the crowding and the congregate living situations that they're in. Individuals who experience homelessness or housing instability really have a very difficult time implementing many of the COVID-related prevention strategies that the CDC recommends. They don't have access to hot water or soap. They are often, if they're on the street, living in or staying in crowded places to avoid violence, for example. And because we also know that large populations of those who experience homelessness as well have chronic illnesses, such as HIV, hepatitis C, pulmonary disease, that puts them at even higher risk for severe COVID illness when they do become infected. Next slide, please. So all of those risks and all of those risks not related to their addiction, to the COVID illness, are things that we really then as providers have needed to quickly pivot and adapt our practices to these extremely vulnerable populations during this pandemic. That is particularly the case, as we mentioned, in terms of those people who are re-entering the community after incarceration. Because the local jails and detention centers have become hotspots, that coordinated re-entry planning, while that in usual times is extremely important and can take a long time, that is particularly key during this public health emergency. And especially because it may be more difficult to find safe and stable housing. Addiction treatment services may be more difficult to access. Some of the residential treatment facilities have closed their doors to new patients. Some of the recovery houses that we work with through my center have really tried to avoid taking patients from jail because of the assumed risk that they have for COVID illness. And because we have individuals with opiate use disorder who may have gotten started or continued on their therapies, their medication therapies, during an incarcerated setting, If that then now gets disrupted, it puts the patient at much higher risk of overdose and overdose death. Statistics out of Washington State within the last year or so have found that the increase, there's an increase of 129 times the mortality rate within the first month of individuals coming out of incarcerated settings compared to the general population. So this is a really vulnerable population, not only for COVID, but also then for overdose. Next slide, please. So because of all of this, as treatment providers, we essentially, and the guidance that ASAM has put together, essentially talks about how patients who are coming out of high-risk environments, so whether that is detention or also shelter type settings, that we need to kind of assume that they may have been exposed to the virus and take precautions for increased infection control and mitigation. And that means using telehealth whenever appropriate and possible, although for many populations, particularly those who are unsheltered or are experiencing homelessness, that may not be possible. We need to recognize across our systems, including treatment providers, parole and probation, judges, and others, shelter managers, that there may be increased stress at an already really stressful time because of the various challenges that these vulnerable populations are facing. And with that may then need come more relapse, more behavior issues, and we as then treatment providers and others who are interfacing with these populations really need to do our due diligence and our and strive to connect with safety net services even more so than we usually do. That includes housing services and Medicaid enrollment, particularly for those incarcerated individuals who may have lost their Medicaid enrollment during their period of incarceration. Next slide, please. So as I mentioned, individuals who are unsheltered also are considered to really essentially, we need to assume that they may have been exposed to the virus, and again, also take the necessary precautions for infection control and mitigation. And so what that means is that using telehealth when that's possible, but when that is not possible because individuals may not have a phone, they may have a phone but with limited minutes, they may also not have the ability to safely store medications such as methadone or buprenorphine that is vital to their survival from their opiate use disorder. Those strategies may not be options for them. And so we need to think creatively about how can we continue to provide the life-saving treatments that we know can save lives, and also help keep people safe from COVID, and keep our public safe from individuals who may that now also be infectious. So some of the strategies that have been used in different areas include things like room-to-room telehealth. So for example, at the treatment program where I work, and I'm the medical director, we actually have identified an isolation room for individuals who either are coming from jail or who have are experiencing homelessness. And so when they come to our clinic, we set them up in the isolation room, and then we do telehealth via a Microsoft Teams channel with the medical provider and their counselor and their other, our peer recovery staff, to really minimize the staff exposure, but really be able to actually get the patient the service that they need. There have also been unique and creative strategies around mobile dispensing units to make sure that patients actually can continue to get their medications when they are in isolation and quarantine. And coordinating with safety net systems where we can actually help people find shelter. We have identified a recovery house coordinator so that we can actually help patients find shelter in recovery houses, in isolation hotels, in isolation in COVID prevention hotels that the city health department has set up in Baltimore City. And it may be that there are some safety net systems that can even provide phones through the federal Lifeline program, for example. Next slide, please. So the strategies that can work are things that we just need to really kind of rethink and re-engineer some of the ways that we have been historically approaching these populations, even during COVID. And for medication delivery, which is really one of the most pressing issues that many different localities have faced, these are kind of strategies to make sure that patients can actually stay in isolation and quarantine when they are COVID positive, or if they have been exposed or are suspected to have COVID, and making sure that they can tolerate actually that isolation, because the isolation increases stress, increases anxiety, especially for people who then have multiple other psychosocial and other conditions that they're dealing with. In doing so, we need to work really closely with community safety net providers to coordinate the delivery of medication. And in mid-March, the DEA provided some guidance to allow for alternative delivery systems for methadone in particular, that is really heavily regulated ordinarily. And places like New York City have set up mobile dispensing units. They have a van that is now traveling around to isolation and quarantine sites. In Baltimore City, we are setting up a kind of a hub and spoke model. So where there are several opioid treatment programs that are going to be providing guest dosing and having staff actually then go out to patient homes, isolation motels, hotels, the convention center, alternative care sites, really all with the goal of making sure that we can continue to provide patients with the medications that they need so that they can then tolerate that isolation and quarantine, and we can reduce COVID transmission to the public. Next slide, please. And then finally, we spoke a little bit also about kind of staff infection risk and minimizing that. And all the strategies that we've talked about, so whether it is telehealth, whether it is room-to-room telehealth, rather than actually having patients who do not have access to technology, using those various different mechanisms to make sure that we minimize staff infection risk is critically important when we're talking about these populations. We want to maintain access to care, but we also need to do that in a safe way for our staff. Next slide, please. And because we can assume, or we should assume, the patients who are coming from these high-risk environments have been exposed, it also is vitally important to provide sufficient personal protective equipment. And that has been an issue across the healthcare system. That has certainly been the issue at the treatment center where I work. We have been lucky in that our state Department of Health has really recognized that opioid treatment programs and behavioral health providers are essential workers and essential healthcare workers, particularly for these populations of individuals experiencing homelessness and coming from incarcerated settings where people are being released every day in large numbers. So we were able to get a small amount of PPE through our health department as a result of that. And there's additional guidance in the ASAM guidances related to infection mitigation in residential and outpatient settings as well for further information. Next slide, please. And as Kelly, Dr. Clark mentioned, that ASAM has released several guidances. And for those of you who are on the phone, I will just read through this. These are the ones that are particularly relevant to treating vulnerable populations. So they include the guidance for criminal justice involved and people experiencing homelessness, as we've just talked about. And we're going to hear more from our other two panelists. Clinical considerations in different settings, as I've mentioned, modifying drug testing protocols, considerations for selecting medications and formulations, transitioning to telehealth. That includes some of the strategies that we've already mentioned, infection control and mitigation, and treating pregnant women with OUD. All of those you can find on the ASAM COVID-19 website. Next slide, please. And with that, I will turn it over to my colleague, Dr. Salisbury Afshar, to take us a little deeper into this topic.
Thanks so much, Dr. Olson. So I'm going to be focusing for the next 10 or 15 minutes specifically on risks for unsheltered populations who have substance use disorder during the COVID-19 pandemic. My background is as a family medicine, addiction medicine physician, and I've worked at Heartland Alliance Health, a Chicago-based healthcare for the homeless entity for the last 6 years. So today I'll be sort of giving an overview of some of the guidance that ASAM has put out, and I'll also be sharing some local experiences from here in Chicago. Before I start, I also just want to recognize, I know several of our other speakers mentioned it, just what a heavy day it is today, and the awareness that many of the patients we serve and many of the people on this call are likely sort of being re-exposed to high levels of trauma. And I just want to recognize and thank all of you for being here and your continued commitment to serving the populations that we serve. Next slide, please. So the ASAM guidance really focuses, the ASAM guidance around supporting people with addiction who are experiencing homelessness really focuses in a few areas. And again, I'll be giving an overview, but we would really encourage people to read the full document on the ASAM website. So it focuses on caring for patients with addiction who are experiencing homelessness during COVID. And we've heard so much and have been really grateful for the new allowances around delivering these services via telehealth. One of the challenges for many patients, including patients experiencing homelessness, is that telehealth can be really challenging. Many of my patients don't have regular access to phone. If they do have a phone, they might not have minutes, or they don't have a smartphone, don't have a data plan. And so as we think about service delivery using telehealth, it's really critical that we think about the challenges that people face if they don't actually have regular access to a phone or a data plan. We also, so then, you know, we are often left with the decision of, do we bring people into the clinic? And as Dr. Olson mentioned, you know, if the decision is made that because people have such limited access to technology, that we do need to leave the option open for people to be coming in and be physically present in the clinic, really to make sure that we have infection control and mitigation processes in place when we can, that we're supporting patients to make sure that they have access to hand sanitizer and face masks, really doing everything we can to protect our patients and our staff. The next area of focus is really around the importance of community coordination. And I think, you know, very appropriately, public health has been really focused on ensuring that there are some safety plans in place for folks who are unsheltered, you know, really trying to work to make sure that people who have known exposures, who possibly need to be quarantined, or who are known to have COVID and need a safe place, especially if they don't qualify for hospitalization, have a safe place to stay during their isolation, that those places exist. I think, you know, one of the key pieces that we've noted that is often an afterthought is that many of those individuals have behavioral health needs. And so if they're just going to this physical space that doesn't have access to addiction treatment services, that doesn't have access to mental health services, and doesn't have access to harm reduction, it can put people in a really tough spot where they're being told they're not allowed to leave, but they you know, may be going through withdrawal, they may be having a mental health crisis, or they may be in need of harm reduction supplies. And so really making sure that substance use disorder treatment providers are at that table, helping our public health systems and these alternate care facilities, shelters, hotels, et cetera, think through what are the critical services that we need to ensure access to. And I'll talk a little bit more about that in just a few minutes. The other areas of focus are really around reducing harms during COVID-19 and the potential impacts of the crisis on drug markets. And I will also be addressing this. Next slide, please. So I mentioned the importance of substance use disorder treatment providers sort of being at the table as public health departments are thinking about isolation and quarantine for individuals who are unsheltered. And so, you know, one of the key things that we really encouraged here locally is that for the centralized system that monitors and supports sort of which patients are going whether they need isolation for having been diagnosed with COVID, or whether they need quarantine for potential exposure, was first and foremost that we wanted to ensure that there was a screening process in place so that people who might be at risk for withdrawal were identified early, so we could hopefully link people to services very quickly. Then, so really helping them figure out what's a really streamlined approach to ask a few screening questions so we can then link to services. At that point, we then need to make sure that there are treatment providers that are willing and able to offer these services, usually through telehealth. Although in the case of methadone, a little bit trickier because that first visit does need to still be in person, but making sure that we have the linkages appropriate and that the alternate care sites, again, shelters, hotels, et cetera, know how to reach us so that we can link people to those services. We've also found that it's really critical to make sure that staff in these facilities have some basic training on how to work with people who are first intoxicated or secondly, maybe in withdrawal. And so often, depending on the site, many of these sites have been historically abstinence-based where if someone was intoxicated, they would just be asked to leave, really recognizing the risks for transmission in addition to just sort of the human rights potential violations of really making sure that people are being treated and getting the services they need. We want to ensure ongoing access to treatment for people who are being isolated or quarantined. And so, for example, if someone who is regularly taking methadone is sent to an isolation unit for being for testing positive with COVID, we want to make sure that we have the medication delivery set up for those individuals, as Dr. Ingvild mentioned. So really re-engineering medication delivery systems. And finally, we want to support delivery of harm reduction services. So also recognizing that there will be some people who continue to use drugs, even while in isolation or quarantine, and making sure that people have the right tools to make the safest choices for themselves will be critical. Similarly, making sure that folks that work in these facilities have access and have been trained on how to use naloxone. Next slide, please. So I think one of the other things when we think about some of the increased risks right now specific to COVID, we had expected and are seeing, at least in some jurisdictions, disrupted drug supply chains. So when we think about patients who are actively using drugs, this can put people at increased risk because it may mean that they either can't get to their normal source or their normal source might not be available for one reason or another, which then means people could be buying substances from someone they don't know, which could, again, lead to sort of increased risk for overdose. We're seeing many people who are, trying to engage in physical distancing, so people may be more likely to use alone, in which case there's no one there to reverse an overdose should it occur. We're also seeing that many people don't have access to income right now. So it could be that they lost a job. It could be that, their normal sort of day labor or other sort of economic opportunities are not available right now, which is putting people at increased risk for withdrawal. We're also seeing in many cities that harm reduction services have had to reduce hours, again, in support of physical distancing efforts because they may have staff that are out sick or taking care of family members. And so people don't have as regular of access to things like naloxone distribution and syringe service programs. Next slide, please. Additionally, we're finding that for many patients, we know at baseline, treatment services can be hard to navigate. But right now during COVID, we've seen many residential programs have to limit intake or in some cases even reduce intake. In the cases where there have been outbreaks, some facilities have had to actually close down services for a short period of time. And so what was historically a difficult system to be able to navigate, I think is increasingly difficult right now during COVID. Again, for people who have limited access to technology, the ability to engage in outpatient programs, which in many cases, at least locally, have moved to being fully online, is really hard if you don't have a phone or you don't have web access. And finally, we are seeing sort of that many people, and this is across the board, are really nervous about going in and accessing emergency care because of concern about, possible transmission of COVID. So in cases where people may be experiencing consequences related to drug use, they may be less likely to go into the emergency room, even as compared to during sort of quote unquote normal time. Next slide, please. So then when we think about the risks for people experiencing lack of housing, and Dr. Olson already mentioned several of these, so I'm not going to go through this in a ton of detail, but I think, during normal times, we know that there's not enough housing access in most cities. And right now, shelters are really trying to decompress. So they're trying to have fewer people to support physical distancing, to, really be able to better track and monitor, to allow for screening, et cetera. And so as I mentioned, we've seen many cities opening these alternate care sites, which has been, I think, helpful, but we're also seeing that we're sort of building the ship as we're already sailing. And so, again, really important that we're thinking about the screening and treatment services that people need and recognizing the need for training of staff who are there. Also important to be considering how do we ensure people in these facilities have continued access to all treatment services, but especially medication treatment services, and that we've streamlined those systems to really support the alternate care sites and the patients in the alternate care sites to getting those services. And finally, many shelters, as I mentioned earlier, have not historically been harm reduction oriented. And I think, this is a unique time because shelters who historically may have said, well, they just can't stay because of X, Y, or Z, we're recognizing now that our role is not only to support the patients, but the broader role of these alternate care sites is also to try and reduce transmission at the community level. So really important that we're doing everything we can to support patients to stay in these facilities for their isolation and quarantine periods to make sure they're as comfortable as possible, which often includes offering treatment services. Next slide, please. So as a substance use disorder treatment provider that's working with alternate care sites, I'm going to just highlight sort of some of our lessons learned and some of the experiences that we've had so far. So I think first and foremost, working with facilities to put in quick screenings into place to ensure that they're identifying folks who are going to be at risk for withdrawal and then linking to services in a timely fashion. And so I'll just share an example here of sort of what could happen. So if someone is coming in to an alternate care site and there's not a screening process in place, it could happen that it's not until they're in pretty significant withdrawal that anyone picks up on the fact that something is wrong. At that point, often it's really hard, especially if you don't have immediate linkages in place, to be able to know how to get the person the services they need to be able to keep them comfortable and be able to allow them to stay there. What we don't want to do is be sending people back to the emergency room, again, sort of transporting people around, particularly people who we know have already been diagnosed with COVID. And so one of the things that we put in place in my own practice is that we have partnered with a shelter that is offering services for people who have been diagnosed with COVID and don't have access to safe shelter otherwise. They've implemented a screening process right when people get there, and then if anyone is thought to have is thought to be at risk for withdrawal, they call us immediately, and then we do our registration process and initiate treatment services as quickly as possible. Next slide, please. I will say that we have lessons learned, and I apologize, I think my lessons learned are on the next slide, so I'll get there. I did just want to say, at least locally in Chicago, and I know this has happened in many other cities, we've worked really hard to try to pair up federally qualified health centers and substance use disorder treatment programs with the identified alternate care sites and shelters to make sure that people have access to at least some baseline of services. Obviously, it's challenging to be able to offer everything, particularly through telehealth, but we have been able to initiate buprenorphine using telehealth to, again, really make sure that we're doing everything we can to keep people comfortable and address their opioid use disorder and withdrawal symptoms while they're there. We've also worked to make sure that the alternate care sites know which OTPs they can work with for methadone delivery. And finally, we have some federally qualified health centers that have actually partnered with street outreach teams to be able to initiate buprenorphine via telehealth for people who are staying on the streets and are not sheltered and not staying in an alternate care site as an additional access point. Next slide, please. So in terms of our lessons learned, I think, first and foremost, the more we can plan in advance, the more we can put some basic screenings into place in advance and really streamline our processes, the smoother the process will go, right, which makes sense. We've seen, at least in FQHCs, we tend to have really robust registration processes that often can take as long as the actual visit. And so we've really had to do everything we can to reduce the burden there, to really, figure out what is the absolute minimum we need to be able to register someone to then be able to have a medical visit and initiate services. We've found that internet access can be really challenging in many of these alternate care sites. So where we can, making plans and adjusting for that, sort of expecting it. Privacy has been another major issue. Ideally, we want to work with the alternate care site to have a space, an office or some sort of small private space so patients can talk to us, about their use disorders, and we can talk about initiating these medications. And finally, really making sure in advance that we have a clear plan for where we're going to be prescribing the medication to, who is going to be able to receive it, where is it going to be stored, is the patient responsible for holding the med, is the site responsible for holding the medication, and if the site, do they have all the appropriate protections in place? And so really just thinking through all of that with the staff has been critical. And so I just want to say, although it's been challenging and we've definitely been learning as we go, I feel confident that we've been able to increase access to patients who really needed it. And I would encourage anyone who's not currently partnering with alternate care sites or shelters to consider doing this, particularly during COVID when we may have reduced hours or other things. I think it's been a great partnership and access for a patient population who really needs the services. Next slide, please. And with that, I'll pass it over to Dr. Waller.
Great, thanks, Elizabeth. So one of the things that I think is important for this whole group of patients that we're seeing on a pretty regular basis is understanding what's happening in the criminal justice system and what that really means for those suffering from an addiction that are both still incarcerated and or released from care. Can you go to the next slide, please? When we look at this, the criminal justice populations with SUD, up to 80% of inmates meet the need for a substance use disorder. And that's been shown year after year after year. And with a population where 8 out of 10 has some version of a substance use disorder or significant use contributing to their criminogenic behavior, this is a really important thing to think about. And the decreased drugs in the jails and prisons has really been interesting to watch, because as they've decreased visitation in the jails and prisons, what we've also identified is less drugs entering prison, so therefore we've had more inmates requesting treatment, having withdrawal, and a number of other things that are occurring on a pretty regular basis. And in this big issue with rapid release without planning, has really created a significant structural dilemma in that for the prisons and jails that have expanded access to treatment, what we have found is that they're being released out into the wild without good coordinated care. They're being released without a time for care management to really structurally set up that release planning so that they can be maintained on medication or set up for ongoing treatment. And therefore, they're basically just being dropped off at the side of the road without an idea of where to go, how to follow up, when to follow up, which really puts them in a situation of distress. And this happens not only for those that are being released from jails or prisons who have implemented the utilization of medications for addiction treatment, but also for those that have an ongoing disorder that wasn't treated inside of the jail or prison, who are now released early with no coordination. And if we also look at things like the lack of access to Medicaid, now this has been an issue in many states where they haven't expanded Medicaid. They've never had access to this, but for those who have access to Medicaid within their state, being able to turn this on quickly enough so that they're able to go out and get an outpatient intake visit somewhere. And this is difficult because that needs to be structurally put in place. There's a lot of paperwork, generally speaking, and that needs to be in place prior to the vast majority of treatment facilities actually booking an appointment for an intake. Not to mention in COVID, where we've actually seen a significant decrease in access to new appointments and intakes. And a lot of these intakes haven't been able to be set up telemetrically because, generally speaking, in the past it had required a physical exam before you can prescribe medication. At least luckily now, we don't have that massive hurdle to overcome for the time being. I am concerned that that will go away when the state of emergency goes away, but definitely right now, release without planning is a big issue in a population that has a predisposition for a substance use disorder without access to medical insurance, and then being able to not get an intake appointment. I don't see how that's exactly a recipe for success in this situation. And we really don't know, because of the testing disparities in some jails and some prisons, if they're being pushed out and they're positive for COVID or they're not positive for COVID, and trying to figure out how we should be doing that testing before they leave. Because I'm a practicing emergency medicine physician, and I will tell you that the rapid tests are not that reliable, in a sense of you can have someone who's very sick with COVID and the longer genetic test comes back as positive, but that rapid test will come back as negative. And we still don't have a good idea of sensitivity and specificity in a population that is asymptomatic. And so trying to figure out, well, is a negative test negative so I can release them? Is that great? Or if they're positive, what do I do? Do we have to keep them inside so that we can make sure that they're in a confined environment to decrease the chances of that being pushed into the population? Or are they trying to get people out so that it doesn't escalate inside of the incarcerated population? This is really problematic, and quite honestly, right now, because of the lack of rapid testing access that we can count on, this has been really a difficult piece. Next slide. If we look at what we're seeing on the ground, and I'm currently running a number of programs that are in charge of implementing addiction treatment into large state prisons, as well as a number of jails around the country. And what we're finding is, as I had stated earlier, inmates really starting to ask for treatment. And most of that is because the drug supply into jails and prisons has decreased. And with that, they're starting to be in withdrawal. They're worried about their thoughts. They're worried about their behaviors. They're starting to have an increase in some violence in some of these areas that haven't expanded access to medication treatment, medication for opioid use disorder. And then the other one is that those that have expanded it are now being pushed to their limits because they may have only one or two providers that do this, and they're starting to creep up on their numbers. And one of the prison systems that we're implementing this in, we've already seen an increase from about 150 to almost 3,000 inmates on medication for opioid use disorder. And trying to keep up with those numbers when you have another few thousand asking for it become really problematic. And the inmates, when you speak to them and you sit down, and we were doing town halls with the inmates, and what I identified is they're really scared at this point because they want help. They don't feel that they can get it. They're scared to death of what's happening with the shrinking drug supply inside of the jails and prisons, in the sense that things are becoming more violent in the ones that don't have access to medication for opioid use disorder. The scarcity creates a lot more cost in order to have access to it. And even if they're released in this rapid fashion without the coordination or access to stable housing, as alluded to earlier, is really all stacking up to be every card against them. And it's problematic. And even if they have housing, so let's say we're going to send them back home, many times the housing that they are in is risky in and of itself. And so because of that risk by itself, it may be because someone is selling drugs. It could be because someone is also still active in their addiction and not seeking help. We're not exactly doing them a good favor by just sending them back home, especially when we haven't set them up for an intake appointment, gotten them insurance, or put them on medication for an extended period of time after use. Next slide. So when we look at the basic points, we definitely want to make sure that we're treating addiction in jails and prisons during the COVID-19 crisis. And this is important. This is expanding all over the country in a number of different places. And I think instead of at the early adoption stage, we're now moving into the meat of the curve when it comes to adopting this, and as we're onboarding it and doing training. When people are going out for re-entry of individuals who have addiction, they should be leaving with naloxone. They should be leaving it in their hands in case they go out, because the average length of time between being released from jail or prison and first use for those not stable is in the first 24 hours. And so we have to give them the ability to not die from a disease so that we can get them to treatment. Medication continuity is really important, and the medication continuity relies on those that are treating them inside of the jail or prison to write them for an extended prescription that gives them a bridge to that next treatment. And what I'm asking all of our sites that we're working with is to write a 30-day prescription to allow for the continuity of the medication to be delivered on an ongoing basis, or making sure if they're on methadone that they actually are going directly to the opioid treatment program to get that first dose the day that they leave. Really important. Community treatment connection, a warm handoff, a phone call to the place they're going to go, even if it is a halfway house, even if it is sober living home or back to their own house, making sure that there has been a direct communication with the community treatment provider is really important, and making sure that where we do send them is safe. I mean, this is a big issue. And I think I would be remiss if I didn't call out with what's going on around the country right now, the reality that if we really want to dig into this from a risk mitigation perspective, that the structural racism that sits within our system is amazing to me, when greater than 50% of the children that go to judicially waived to criminal court are African American. A significant disproportion of those that are in jail or prison are African American or Hispanic as compared to whites. So it does play into this, and I would say that we need to begin the review of both federal and state laws and local ordinances and sentencing guidelines that have a racial bend to them, so that we can, as we get people back into the community, make sure that we're doing this in an appropriate way and not ignoring the herd of elephants in the room. Next slide. And as we look at this, the considerations for treatment providers, they have to know that they can absolutely treat these patients. These are humans. These are just people who have a disease and they can show up. But I think the fact that somebody has been incarcerated really increases the chances that somebody doesn't want to see them because they're worried or they're scared or they think that it's a completely different thing. But this is just a person with a disease that has a different set of structural realities. And we need to be able to support those that are trying to deliver care, and federally qualified health systems, health centers or hospital systems, emergency departments, primary care. All of those need to be equipped with the knowledge and capability that this subset of the population is no different than anyone else. They just have some extra baggage that we're going to have to help them carry as they get stable. The considerations for probation and parole are really important because they are the key contact when somebody leaves prison, and many times for those that are leaving jail. And if that is the case, we should use that to our advantage and make sure that parole and probation officers are really focused on making sure that they have access to treatment. For those that have diversion programs or the capability to deliver treatment themselves, that they're helping to rapidly maintain access to the medications that they were on and or the treatments that they were on for their other substance use disorders. Because while we're focused on opioids, I mean, the reality is addiction is a much bigger disease than just opioids. And we have to think about those with an ongoing alcohol use disorder, methamphetamine use disorder, marijuana use disorder. All of those need to be taken care of as a larger chronic neurobiological disorder than just one medicine for one disease. And if we do that and we support the people trying to deliver care, then we're more likely to be able to get intake visits and placement as we move forward. Next slide. And the coordination with the safety net, I mean, if you're leaving jail or prison, 99% of the time, the safety net is all you have. You're going to show up and you're going to have coordination with community treatment that is funded by the county or block grant or state. If you're lucky enough to be in a state with expanded access to Medicaid, then you need to be able to get on that and get that piece of funding so that you can see all of the people that you need for good coordinated care. The housing services and the experience that I've seen in California and in their prison system and 27 jails that we're implementing addiction assessment and treatment in is the biggest hurdle they have, other than all of the things I've mentioned, the basics of small things like structural racism, the fact that they're underfunded, the fact that we have stigma about addiction and all of these pieces. One of the other big things is making sure that when people leave, that they feel comfortable that they're going to go somewhere and get treated like a human being in an evidence-based fashion for the disease that they have. And that is the goal for all of people in the United States that have a substance use disorder. And we don't have to separate this because they happen to be incarcerated, because eventually they won't be. Right now they may be in jail or prison, but next there's somebody's neighbor. And so we have to build the continuity of this system in there. And if we don't, we're going to miss a real opportunity to stabilize one of the most vulnerable populations we have. Next slide. And with that, I'll hand it back to the group so that we can answer your questions and hopefully make sure that we've gotten specific enough for you so it doesn't feel too 30,000 foot, and we can answer some things down to the weeds for you. Thanks.
Well, thanks, Corey. Appreciate your comments and everyone's comments to date. I would like to remind everyone that you can upload your comments into the chat box. We are monitoring those, and they'll be available for us to address as we go along. So I'd like to start off with something that each of you mentioned, but I just want to make sure you have an opportunity to make this very clear about people leaving a situation where they've been away from drug use, that they've been physically away from that, either incarceration or an inpatient kind of unit, and what it is that is the primary thing that will decrease that risk of death for them in that immediate post-release time period.
Well, I would say access to leaving with naloxone in their hand and maintenance of the medication that they're on. I mean, those are the two things that always show a decrease in mortality, no matter what the population, but specifically in those leaving an incarcerated situation. I mean, if they have those two things, then they are less likely to die.
And for those who are on the call that are not addiction medicine physician experts, by maintenance medication, you mean?
Buprenorphine, methadone, or naltrexone.
Great, thanks.
And I would add perhaps that, specifically methadone and buprenorphine are the two medications that have really have the significant evidence for a reduction in mortality.
Yeah, in fact, there are a number of large-scale studies that just came out that showed that only buprenorphine and methadone showed a mortality benefit over time as compared to naltrexone. No, that's a great point.
Yeah, and this is Elizabeth. I would just add, I think working with particularly a lot of primary care providers who have a waiver to prescribe, there's often fear or confusion around whether or not it would be appropriate to initiate buprenorphine for medically managed withdrawal or not medically managed withdrawal while incarcerated. And this absolutely can be appropriate. The main guidance is just that you want to start at a lower dose and sort of increase more slowly, particularly depending on the duration of time that someone had been without opioids in their system. But I think there's, again, often a lot of fear that if that first detox is negative, even if we know somebody just left incarceration or we know they just left medically managed withdrawal in a residential setting, that it is still appropriate if they meet the diagnostic criteria for OUD and you feel that the benefits outweigh the risks. So just wanted to add that in there.
Thank you. A couple of questions actually come to a point of asking for data. There's a question about what is the estimated magnitude of increased risk that patients with addictive disease have to COVID and severity of COVID disease illness when they become infected. And another is how impactful have been the efforts to enhance psychoeducation to patients about COVID. And both of those, I think, are great questions in and of themselves, but I think there's a meta question here about data gathering and what has happened to our knowledge base and our database during COVID-19. So I'd like to open it up for any of you who'd like to address the questions and then the meta question.
So one thing I would add is I'm not aware that there are any specific statistics that we have that could actually kind of give us an answer to what is the absolute risk or what is the relative risk for transmitting COVID to patients with addiction. I will say that I think, if you look at, SAMHSA estimates that 50% of individuals who experience homeless have a substance use disorder. And so when you factor in kind of all the risk factors related to congregate living situations, unsheltered, being, in prisons or jails, kind of just the risk factors of physical kind of closeness and the risk of transmission that goes along with, as well as that when you think about, for example, in my population, 75%, between 75 and 80% of the population that I serve has at least one of the conditions that puts people at risk for severe COVID illness. So whether that's pulmonary conditions, cardiac conditions, smoking. Smoking certainly seems like it actually kind of puts people at higher risk for severe COVID. And there was an analysis that was done by a group out of a couple of different universities across the country, UCLA, BU, and UPenn, that estimated the risk of severe COVID for people who were experiencing homelessness. And it looks like, anywhere between 2 to 4 times more likely to need hospitalization, to need ICU care, and 2 to 3 times more likely to die as a result of that COVID illness compared to the general population. So, certainly I think some sobering statistics around kind of that these are very vulnerable populations that we're talking about, related to COVID, but then we also know kind of what the mortality risks are related to untreated substance use disorders, particularly opiate use disorder.
Yeah, I agree with Dr. Olson. I haven't seen any specific recommendations. I think that we recognize that there are so many individual and community level factors that are likely to impact one's risk. And it's complicated. So even if we could make a general number, I think we would recognize that based on baseline prevalence and sort of drug supply in a community, like there are just so many factors that can be put into this. But I think to the question that Dr. Clark, when you think about data collection, and I've worked in public health prior jobs, particularly data collection as it relates to.
You're breaking up here. I'm having a hard time hearing you. And I think it's when
sorry.
you move. So
Okay.
if you could hold steady, that'll help.
Thanks.
Get you an antenna.
Got it. I don't have the most comfortable office set up here in my basement spare room. So sorry about that. But yeah, I would just say that I think we are really lacking with regard to data. I mean, we all know that we've had really limited capacity for testing in most places. It has not been what we would have liked. But then as it relates to even collecting data on folks who have been tested, what their risk factors have been, contact tracing has been challenging, particularly in cities in locations that have had really high rates. So I think these are questions that we'll be trying to answer for the next few years as we look through the data that becomes available over time. This is not something that we've seen a lot of really great analyses happening in real time just because there's so much happening at once.
Dr. Waller?
No, I mean, I agree. The data for prisons and jails right now is always going to be tough because it's been difficult historically, and it's no different now to get any data out of jails and prisons about what's actually happening, about density of testing, percentage of people with positive or negative, and who was sent to the hospital or who just stayed there. This is going to be tough. There are a few that we may be able to get retrospective data from, but I think within the incarcerated population, you're going to look at certain areas that have overpacked jails and prisons, where we're going to see the same thing we saw with healthcare providers, which you're getting a higher viral load. So you may end up with a worse variation of the disease, no matter what your health state. And generally speaking, the people inside jails or prisons are already at risk because of other health conditions. Again, hearkening right back to the racial disparities of people who sit in jails and prisons and risk of, hypertension, hypercholesterolemia, and the disproportionate impact on the African-American population as a whole for COVID. We're going to see that inside of prisons and jails, and for those that get released out into, quite honestly, chaos in many communities right now. And it's going to be really difficult to get good numbers long-term. I will say that I would be really surprised if we don't see a pretty significant spike in the populations that we've seen in the next 2 to 3 weeks for people there in the emergency departments and in ICUs.
Yeah, I guess it's not very surprising to hear, Dr. Olson, that 75% or so of your patient population have one of these chronic diseases, because I think about half of the United States adult population has one of these chronic diseases. And it's well known that as a psychiatrist, within folks with psychiatric disorders, there is an increased prevalence of chronic disease as well. So that's not particularly surprising. And I am also aware that what we have lost over the past few months are some of the data collection and some of the data being available about overdoses, about deaths due to opioid use disorder and other diseases. Because data is powerful and it's valuable. And so there have been a pivoting of the resources that are around collecting and analyzing data in some situations from those around addictive disease to COVID. So there has been sort of a paucity of some data recently because of this. I want to address a couple of the questions that have come up very quickly so that we can go back to some questions. There's a question about using telemedicine, particularly around the use of urine drug screens, urine drug testing, and I want to focus the questioner to the ASAM guidance on reconsidering the use of urine drug screening and testing in treating addictive disease. Similarly, questions about telemedicine, a number of guidance documents there on the ASAM COVID website. Some additional questions about, why after so many educational programs and awareness campaigns do we still have to battle with so much stigma? I would refer the questions about this as well to the National Academy of Medicine. There was an entire webinar panel on this about a week ago. So there's a pretty robust discussion of the stigma issue there available through the National Academy of Medicine site. One of the questions, actually a couple of questions, are around cutbacks being made in the Medicaid system, particularly as states are going to be bearing this burden of decreased revenue due to COVID and other issues. And one of the things that I think it was Dr. Olson mentioned about doing room-to-room telemedicine. I'm aware that in some states, it has been determined, and the academic medical centers have been told that that's not billable. It's not a person-to-person encounter, and it's not really a telemedicine encounter. And so I wanted to give you the opportunity to address some of the questions that have come out in this larger construct around payment and how that is related to accessing treatment throughout addictive disease, but particularly here in the homeless population, and as well as the justice-involved persons population. So I'll open it up to each of you.
The main thing I would like to say about payment is that we passed the MAPIA back in 2008, the parity law, and then a couple of years ago made that apply to Medicaid. We still don't pay for addiction treatment in the perfect system. Like if you have this, we pay for it with the lowest margin of anything. If you decide to go into addiction medicine and treat somebody, whether you're a therapist, a nurse, a physician, a peer, you get paid less than your cohort who does that same job in a different disease state. So there's already structural inequity in the baseline support for this. So quite honestly, if Medicaid starts to cut this, it's against the law to continue to cut in this area as compared to others, because it's already not at parity. And it's unethical because we know that it's the baseline of the vast majority of diseases that we have trouble treating. If you have someone with a mental health disorder, homelessness, or a substance use disorder, and we don't treat that, you're not going to treat their diabetes. You're not going to treat their hypertension. It's a joke if you're going to have them calorie count or carb count for their, insulin injection. And so I think people just need to be very clear that when you're reconstructing your payment modality for who you're going to cover and what you're going to cover with decreased revenue, you make sure that you recognize that addiction treatment has not been at parity ever. And we cannot take structural cuts to this area that are either disproportionate or equivalent to the other deliverables within medical care.
Yeah, I would certainly concur with Dr. Waller wholeheartedly. I mean, I think, we have so much evidence also that treating addiction and mental health conditions has cost savings to a whole host of different systems. And so if you're really kind of thinking now about, cutting costs to Medicaid, it's kind of like shooting ourselves in the foot. Because now you're going to have then increased costs in all these other places, whether it's in emergency departments and hospitalizations and, incarcerated settings. And now that we really understand just how interconnected all of our systems are, particularly when it comes to these populations, and that the public health really rests on and our ability to get a handle on the COVID situation, it really means we cannot continue to ignore, people who have been blind to us for the most part, for so long, because it affects all of us. And so I completely agree that, I think not only would it be illegal, but it would be really just kind of idiotic in my mind to kind of really try and save a few pennies, kind of relatively speaking, on the behavioral health side, to then kind of try and balance state budgets with respect to Medicaid, because it really is in the end just end up costing us all of us as taxpayers, just a lot more.
I think that what's been stated is been really well said. I don't know that I have a lot more to offer other than to say that, we've been having a lot of conversations within the FQHC community about sort of how will we continue this sort of once the national emergency is no longer in place. And I think, the answer is we don't even know what's going to be allowable. And really for us, if we aren't getting paid for it, we can't afford to continue to deliver it. And we've seen a lot of positives for patients. I have patients that travel by 2 buses and trains from surrounding suburbs who are now don't have to take a day off from work to be able to see me. And I think we've seen a lot of positives through being able to get paid for telehealth services. And we are really hopeful that it will continue, because I think it definitely has a place, but we know we can't afford to continue to offer it if we aren't reimbursed for the services that we're delivering.
All very well said. I would say on the issue of idiocy, as Dr. Olson has said, about decreasing access to behavioral health services, that I've heard very widely of hospital units that are psychiatric as well as substance use, but primarily addictive disease units being shut down, decrease in number of beds in order to make room for real patients with real diseases. That's in quotes for those of you who are not on the video here. And so on. And so there is a very real sense, I think, out there among addiction treatment providers that there is a movement to push what's already a marginalized and siloed disease state and treatment system even further away. So I would call out that that's there, idiotic or not. So for some additional questions, just for those of you who may not have seen it, there is a link to the National Academy of Medicine session on stigma, which is in the chat box. You can grab that link there if you're interested in that topic. A couple more interesting questions around here, and one that I think is really important for us to comment on right now is the information specific to the Native and tribal populations. I don't think I need to say anything more to any of you. If you'd like to comment, please.
Yeah, no, we're doing some work with the Indian Health Service right now, and it's come down to individual tribal nations and how they've approached some of these things. I mean, one of the biggest issues is that because most of the tribal nations are many times closed-linked, so they're encapsulated into a tighter knit population, and they receive the vast majority of their at least lower-level healthcare within that population at Indian Health Service clinics. We've found a significant disparity in access to a number of things because their health system is set up very separately from the average American health system. It's funded differently. The way in which the federal funding came down actually missed the mark on being able to help them almost in any way for access to extra tests, extra PPE, and those things. And so they've been forced to basically wall off their tribal communities from the rest of the people around them and just trying to isolate even more. But as we said earlier, they are one of the populations that absolutely has an increased risk to this. And with me working I was asked to come out and deliver some direct service in one place, but I couldn't because I work in the emergency department. And the last thing we need is somebody like me who's high risk for contracting popping into that. And I know a number of my colleagues that are in the same position where they would like to, but the risk of what we're doing is problematic, but there has not been a systematic approach that I can identify, nationally to approach this within that tribal community. So they're kind of on their islands at this point.
Well, we've got about 5 minutes left before I'll send it back to Liz to wrap up our session here. And we've had a number of questions about harm reduction approaches. And here I'll just define harm reduction as being rescue, naloxone, needle exchange. Don't consider the use of medications in treatment to be harm reduction, of course, that's simply treatment. But just wondering in terms of, and I think you've made some comments about this, but in your work with the incarcerated, the justice-involved population, and those who are unhoused. If you could talk about the utilization of those harm reduction techniques and/or the use of field strips for determining if there's fentanyl that's been tainting the drug supply is another harm reduction approach. I'll send it to you.
Yeah, so I'll start and then pass it over to others. But I think, so first, sort of just being aware of what harm reduction services are available in your community and knowing if they've changed services is really critical as we work with patients. And so, that's something that often happens at a local level. For anyone who's a prescriber or has a prescriber affiliated with your organization, ensuring that there's standard policy and protocols around ensuring people have access to naloxone, whether it be through direct distribution from your setting or whether it be through a prescription. Obviously, the prescription is more helpful when you're in a state where it's a covered service, often by Medicaid, but really doing everything we can to support patients to navigate while services may be disrupted. I think it is sort of where I would focus my energies right now. And then, as I mentioned, here in Chicago, we have some of our harm reduction agencies that have partnered up with FQHCs to be able to actually, as they identify folks who are interested or willing to try buprenorphine, to offer those services literally out on the street through engagement through a telehealth encounter. And so really just sort of thinking creatively about all the circumstances that may make it harder for people to reach us. So what are the ways that we can reach them through partnership, including with harm reduction providers?
Yeah, I would just add that I think partnerships is really the key. And, so partnering with your local harm reduction coalitions, your, homeless outreach teams. We actually were really lucky in the state of Maryland where our Maryland Department of Health actually, has had a very broad and robust naloxone distribution program kind of even pre-COVID. And they really focused during COVID on making sure that they actually use their grant funds as much as possible to then purchase and distribute naloxone to opioid treatment programs, to the homeless shelters to, a variety of different entities, because most of the syringe service programs actually closed their doors. And so they, so in Baltimore City, for example, there was very little access for a while to those types of harm reduction resources. We, in fact, actually had partnered with a kind of a peer-led coalition and an agency that has been providing fentanyl strips and other harm reduction messaging kind of to our patients in our lobby. We had to put that on hold during COVID, but we actually are continuing to provide the messaging and all the information and some other resources to patients as they come into our opioid treatment program, and still are handing out, as much of that messaging and education as possible to patients, even when we're going and delivering medications, et cetera.
Great. Well, I'm going to address another question here very briefly, and then I'm going to go back to each of our panelists and offer you 30 seconds to give your final words of what you'd love people to have as a take home, and then let Liz take us out here. But there are a number of questions here about people who need to access mutual help and peer services in peer support groups. I would refer you again to the ASAM COVID website, where there's guidance about physical distancing in in-person groups, as well as to the use of technology to do virtual support groups. So with that, I'll go across the board from my left to my right of who I'm looking at, which will be Dr. Waller, Dr. Salisbury Afshar, and Dr. Olson, who I must thank again and say for any of you who did not know that addiction medicine is a board's approved specialty. You've just heard from some board certified addiction medicine physicians and representing the field very well. So Dr. Waller?
Yeah, I think thank you for that, Kelly. And I think the biggest thing that I'd like to leave with is a basic understanding of the fact that the systemic aspects of structural racism inside of the justice system is the tip of the spear and the base of the pyramid for all of the aspects of what it is. If we did this correctly, if we sentenced African Americans at the same way we did whites, we would have 40% less people in prisons and jails. And so if we just look at that basic and start with that, knowing that they have a higher risk for COVID-19, they have a higher risk for lack of access to healthcare, they have a higher risk for lack of access to addiction specialty providers, then if we really dig in, we're going to start to find out that if we just make things normalized across that, then we have the ability to decrease the risk to all involved in this, and not just a subset. Elizabeth, you're on mute.
I keep double muting, sorry. So I just want to say thank you for that. I think when we look at data around populations who are experiencing homelessness, we see similar disparities and disproportionate impact, particularly among African American populations. And so we're seeing this really compounding impact. And so I think, on a very practical level for treatment providers out there, I guess my main takeaway is, if you are not already, please be thinking creatively about how you offer outreach services, how you partner with harm reduction agencies, with alternate care sites, with homeless shelters, et cetera, to make sure that people have access to services, and that we are really using, I hate to call it an opportunity, but the opportunity that we're allowed to offer services via telehealth, that we're really utilizing that opportunity to reach folks in different ways, and that we're being creative and we're being thoughtful and we're being mindful of the structural and institutional racism that exists that is putting people at additional risk.
And I would add that, I think this is clearly an unprecedented time in our country's life, in our lives, and I can only really hope that together, out of all the unrest and the anger and the despair, that if we really kind of pay attention and realize that we are all in this together, we are going to need to be together to get out of this together. And that means that we cannot continue in the same way that we have with the structural racism, with the inequities that we have tolerated for so long. And that, you know, these populations that we're talking about today are at the heart of some of that, but there are many others, and we just need to really kind of stop and look at each other as fellow human beings who have various different conditions that we all come with, but that we can all really together kind of get out of this, because I have hope that, that together we will.
Thank you all. Liz, would you like to summarize and end this webinar?
Yes, thank you so much, Kelly. This has been a really incredibly timely and informative session with a lot of terrific discussion, and I can't thank all of you enough for the good work that you do and for all your sentiments today. I think this is, as I mentioned, a very timely and important discussion to have, so thank you. I'll just conclude today's webinar by extending our special thanks to ASAM, and again to all of our speakers, and of course to the webinar attendees for participating and taking the time. As was mentioned throughout the course of the webinar, we did record today's session, so you will find the webinar recording, the speaker's slides, as well as information on continuing education credits at nam.edu/treatment-webinars. So again, thank you all very much for your participation today. Everyone, please stay safe and well, and enjoy the rest of your days. Thank you.
Thank you very much.
Thank you.